Hi everyone, today's talk concerns right ventricle and its pressures. So we'll start with the concept of ventricular interdependence, and ventricular interdependence refers to the concept that the size, shape and compliance of one ventricle may affect the size, shape and pressure volume relationship of the other ventricle. And that occurs through direct mechanical interactions. So the continuity between the muscle fibres of the RV and LV functionally binds the ventricles together, and together with the interventricular septum and the pericardium, this contributes to the concept of ventricular interdependence. It's also important to consider heart-lung interactions, which is particularly important in our patients and those that are mechanically ventilated. It's not really the focus of this talk, but hopefully we'll get to it in subsequent talks. So you can see in the images on the slide here, so first in the still image, you can see that the interventricular septum remains concave towards the LV, and that's mirrored in the loop on the right side of the slide. So that's a normal looking interventricular septum. So the LV is a nice donut shape and it's concave to the LV throughout the cardiac cycle. So normally when the RV receives preload, it's the RV free wall that expands to accept it. But in circumstances where the free wall cannot stretch anymore, RV filling results in deviation of the septum towards the left ventricle, and that's what's known as this D-shaped septum. The RV will also dilate, and you'll see septal flattening or the D-shaped septum if it's pressure overloaded. The septum is best interrogated in the parasternal short axis view. Chronic dilatation that may occur in the chronically volume overloaded RV, so the isolated volume overload. So an example of that would be TR. This results in firstly progressive lengthening of the base to apex dimension, but also the free wall to septum dimension of the LV. And as it gets worse, the RV apex can actually replace the LV as the true apex of the heart. As I said, in circumstances where the free wall can't stretch anymore, RV filling results in deviation of the septum towards the LV, or a D-shaped septum. And if it's a strictly volume overloaded RV, so just a volume overloaded RV, you'll see septal flattening in diastole. So it's at its greatest in diastole. And that's when the RV is filling, so this volume will be greatest. When the RV is pressure overloaded, so an example of that may be a pulmonary embolus, the septal flattening predominantly occurs during systole. Usually it's not that simple. Of course, you can have both. But to comment accurately, it's important to slow the image down and look at your ECG and work out where you are in the cardiac cycle so that you can make an accurate comment about when the septal flattening is at its greatest or it predominates. It's important to know that significant conduction delays, so especially a left bundle branch block, can cause abnormal septal motion and make it look like there is septal flattening where there isn't RV volume or pressure overload. And also just know that the D-shaped septum is not diagnostic in RV overload. If it's present, additional emphasis should be placed on confirmation and determination of right-sided pressures and volume overload. So it's an important sign, but it's not the only one you need. There's this index called the RV eccentricity index, and it's the LV anterior posterior dimension to the septolateral dimension. And you can measure that in the parasternal short axis view, just with calipers, with a frozen image. And if that index is greater than 1, then that's abnormal, and it's suggestive of RV pressure or volume overload. So you can see here, this is an example of an overloaded RV with septal flattening. Okay, so moving into measurement of the actual pressures. So the first one we're going to discuss is RVSP. So RVSP is an estimate of systolic pulmonary artery pressure. And RVSP is reliably determined from the peak tricuspid regurgitation jet velocity. And then once that TRV max has been measured, the simplified or modified Bernoulli equation converts this velocity into a pressure change. So the pressure is equal to 4V squared, which is here on the slide. In the absence of any gradient across the pulmonary valve, RVSP is equal to systolic pulmonary artery pressure. You measure this by using continuous wave Doppler through the TR jet, and that gives us the TR peak velocity. You should measure this in multiple views, so you can measure it in the RV inflow from the parasternal window. You can measure it in the parasternal short axis at the aortic valve level, and also in the apical forechamber, and you should attempt to do it in all of those views. To get your true RVSP right atrial pressure is added to the TR max pressure gradient. Normal is less than 36 millimeters of mercury. As I said, your PA-SP or your pulmonary artery systolic pressure equals RVSP if there's no obstruction at the level of the pulmonary valve, and if there is a gradient across the pulmonary valve, then the pulmonary artery systolic pressure equals RVSP minus that pressure gradient. If there's what we call wide open or free flowing TR with rapid equilibration of pressures, then you may actually underestimate the RVSP. And now I mentioned you must add the RR right atrial pressure to calculate the RVSP, and RA pressure is most commonly estimated by IVC diameter, by measuring that diameter, and the presence of inspiratory collapse of the IVC. As right atrial pressure increases, that pressure is transmitted to the IVC, resulting in reduced collapsibility with inspiration and progressive IVC dilatation. And combining these two parameters results in pretty good estimation of RA pressure in most patients. So the measurement of the IVC diameter should be made at end expiration, just proximal to the junction of the hepatic veins. And that image is obtained in the subcostal view. So you take a still image and then measure the diameter, and then you also need to take a loop so that you can demonstrate whether or not there's collapsibility of the IVC. Some people also use M mode here through the IVC to demonstrate that collapsibility. So at the extreme, so a normal right atrial pressure would be so if you an IVC that is less than 2.1 centimeters in diameter, and has greater than 50% collapsibility indicates a normal right atrial pressure. So we would add 3 millimeters of mercury to the pressure gradient that we calculated from the TR peak velocity. At the other extreme, if the IVC is greater than 2.1 centimeters in diameter and has less than 50% collapsibility, then that indicates a high right atrial pressure, and we would add 15 millimeters of mercury. And then everything else in the middle is kind of mid-range stuff, and we would add 8 millimeters of mercury to what we had calculated from the TR peak velocity. In that middle ground, that kind of 8 millimeters of mercury ground, it's less reliable, and unfortunately for us, IVC collapse does not accurately reflect RA pressure in ventilator-dependent patients. So the same principles can be used to measure pulmonary artery diastolic pressure and mean pulmonary artery pressure. So pulmonary artery diastolic pressure is estimated using the PR end diastolic velocity and applying the simplified Bernoulli equation. And likewise, mean pulmonary artery pressure is estimated using the PR peak velocity and applying the simplified Bernoulli equation. And you can obtain these velocities using continuous wave Doppler on a PR pulmonary regurgitation jet, which is seen in RV outflow views in the parasternal long axis, and you can also see it in the parasternal short axis at the level of the aortic valve. You can also calculate the mean pulmonary artery pressure using your SPAP and diastolic pulmonary artery pressure. If there's obstruction, so therefore a high gradient across the RVOT or pulmonary valve when usually there isn't, you can still calculate your pulmonary artery systolic pressure, and that is equal to the RVSP minus the mean gradient across the pulmonary valve. And the mean gradient across the pulmonary valve is calculated by using a CW trace through the pulmonary valve and then tracing that spectral display. I think it's just important to have a think about what we're actually measuring when we measure RVSP. So if it's elevated, what's the relevance and importance of that? So we're using RVSP to estimate systolic pulmonary artery pressure, which is an estimation of RV afterload. And that's what we're really interested in. And afterload can be conceptualized as the resistance to ventricular ejection, or the load that the heart must eject blood against. And its major determinants are firstly wall stress and also impedance. And wall stress can be described by the law of Laplace and therefore depends on the transmural pressure, P, which is the difference between the intrathoracic pressure and the ventricular cavity pressure. And an increased transmural pressure increases afterload, and a decreased transmural pressure, like with positive pressure ventilation, actually decreases afterload. R is the radius of the ventricle, so an increased LV or RV diameter increases wall stress at any given pressure for its respective ventricle. And then also the thickness of the ventricular wall. So a thicker wall decreases wall stress. And then impedance is contributed to by arterial compliance, arterial resistance, and inertia of the blood column. I guess the importance is that the RV tolerates increases in afterload very poorly, especially in the acute setting. And that has significant, a significant impact and consequences for the patient and sometimes for our management as well. So that's why why RVSP is a reasonably important measure for us and for our patients. And then I guess the next question is, why is the RVSP elevated? And you can also think of a change in pressure as equal to the flow times the resistance. So RVSP may be elevated in the setting of increased flow states. So for example, sepsis, which is common in our patients, but there's also conditions of increased resistance. In the adult population, in the normal population, this is most commonly due to left heart disease causing increased pulmonary vascular resistance. And there are other causes as well. So pulmonary arterial hypertension, pulmonary hypertension due to lung disease and hypoxia, and other rarer causes, thromboembolic disease and the other multifactorial kind of category. So this also illustrates that in our patients, you can't really assess the right heart with echo or any other way without taking into account the function of the left ventricle as well, given that left heart disease is the most common cause of increased pulmonary vascular resistance. And just to follow on from that and emphasize again that the elevated SPAP or elevated RVSP does not always mean elevated pulmonary vascular resistance, because as I said, pressure is equal to flow times resistance. You can calculate the pulmonary vascular resistance from echo parameters, and it can be calculated using the ratio of the peak TR velocity to the RVOT VTI, and then you can calculate the pulmonary vascular resistance with this equation at the bottom right of the slide there. It's given in millimeters of mercury per minute per litre, which is numerically equivalent to Wood units, and normal is less than 2. All right, so let's look at some loops. So this is a parasternal long axis view, where we always start in the zoomed out view. The thing that is noticeable in this image is that the LV function looks decreased. And as we zoom in further on the heart, again, already the LV function looks decreased. So this is an RV inflow view from the parasternal long axis view, and there is colour over the tricuspid valve. And then with CW, it's not obvious that there's there's no obvious jet of TR there, but then with CW over the valve, we can see that there is tricuspid regurgitation and measure the TRV max, which is 3.2 meters per second, and a pressure gradient of 40, which is already slightly elevated. And again, another view of the RV inflow. RV outflow. And from there, they've measured the RVOT Vmax and also pressure gradient and VTI. And that's been measured with pulse wave Doppler. And then a continuous wave Doppler over the pulmonary valve to measure the maximum velocity through the valve. And you can see there it's 1.1, which is normal. Normal's less than 3. And now we've moved to a parasternal short axis view at the aortic valve level, which is right in the middle there. And the tricuspid valve you can see just on the left of screen, and the RV outflow tract is on the right of screen. And the left atrium is inferior to the aortic valve. So this is colour over RV outflow and the pulmonary valve, and you can see a tiny flash of PR. And now they've swung around to focus more on the tricuspid valve, which is a little bit tricky to see, but sometimes this is the images you get. And then colour over the tricuspid valve, again looking for TR. It's a little bit hard to appreciate, I think. And so they've adjusted a little bit, panned through the valve a little bit, and now you can see a flash of light blue TR coming back through the tricuspid valve. And continuous wave Doppler through the TR jet, which again has given us a gradient of 47 millimeters of mercury, which is consistent with the measurement from before. And now we've moved down to the parasternal short axis view at the level of the mitral valve. And again, the LV function looks decreased. Certainly doesn't look normal. And we move down further. This is at the papillary muscle level, which again is showing globally decreased LV function. Moving down a little bit further, which is confirming our findings. And now we've moved to the apical 4-chamber view. And again, what you can see here is an LV which we haven't measured it, but does look a bit enlarged, and its function is decreased. Compared to the LV, the RV looks normal size. It doesn't look enlarged, but as I said, we haven't actually measured the size of the LV at this stage. The RV function looks more vigorous than the LV function, but probably still a little bit depressed. And then the RV function has been measured with an RVS prime, which is actually normal at 12.8 centimeters per second. And then move to an RV focused view. So the RV free wall is thickening, and there is, shortening from in the base to apex dimension. And another RV focus view, just trying to really optimize that window. And measurement of the RV basal diameter, which is normal. And then colour over the tricuspid valve. We can see that TR a bit more clearly there. So the light blue jet back into the right atrium during systole. And the TRV max has been measured again, and it remains elevated, consistent with previous measures at 50 millimeters of mercury. And again, the sonographer's just really trying to optimize that TR jet as best they can, and repeating the measurements to ensure consistency. Now move to the IVC, which is 1.5 centimeters in diameter, which is not dilated. And an IVC that's collapsible by, I think, at least 50%. So that would be indicative of a right atrial pressure of 3. And so we measured the RVSP. The pressure from the TR Vmax was at its maximum 51 millimeters of mercury, and the right atrial pressure is about 3, so we'd add 3 onto 51, which is 54. So our RVSP would be 54 millimeters of mercury, which is significantly elevated. And for our purposes, that's probably enough. RVSP is definitely the pressure I measure the most, and that a lot of us will measure the most. Sonographers and cardiologists will measure the other pressures. They have other reasons to measure them, but for us, RVSP is usually enough. Okay, another example. So again, always start in the parasternal long axis view. You can see a few things here. There's what looks like a large left atrium. The LV function looks reasonably vigorous in this view. There's a tiny pericardial effusion and also some pleural effusion as well. And zoomed in, again you can see the right ventricle at the top of the screen it's difficult to make much comment about that now. And you can see the aortic valve opening and closing, the mitral valve opening and closing. In this window, a reasonably vigorous LV and the impression of LA dilatation and that small pericardial effusion at the bottom there. Some colour has been put over the mitral and aortic valves, and you can see some mitral regurgitation there. And again, we've moved to RV inflow. So from the parasternal long axis view, the beam has been tilted down towards the hip. And you can see the tricuspid valve in the middle of the window there. Right ventricle at the top of the screen and right atrium at the bottom. And then colours placed over the valve, and you can see the bright blue jet of TR shooting back into the right atrium. And then with CW through that TR jet, max velocity of 3.4 meters per second has been measured, which equals a pressure gradient of 48 millimeters of mercury. So now we've moved to RV outflow. So from the parasternal long axis view, we have tilted the beam up towards the patient's shoulder. And you can see the pulmonary valve towards the top of the screen there. And you can actually see in this image the main pulmonary artery trunk and then the left and right main pulmonary arteries, which people call the trouser leg appearance. And if we put some colour on that, it might be a bit clearer. And you can see the jet of PR, the flame of PR, pulmonary regurgitation heading up towards the top of the screen. And then pulse wave Doppler to measure the VTI and the RVOT Vmax. That all looks normal. And then continuous wave Doppler through the valve to calculate the peak gradient, which is also normal. And then above the baseline, they've captured with continuous wave Doppler that PR jet. So if you wanted to measure your MPAP and the end diastolic velocity, you can do it here for the pulmonary artery diastolic pressure. We've now moved to the parasternal short axis view at the level of the aortic valve, right in the middle there, and we can see the tricuspid valve on the left, the pulmonary valve on the right. Colour over the pulmonary valve, again showing that nice jet of PR. Most people have trivial PR. This looks a little bit more than trivial, but you will see a tiny flash in most patients. And colour over the tricuspid valve, which is showing tricuspid regurgitation. And they've continuous wave Doppler through the TR jet, giving us, again, a max pressure gradient of 48 millimeters of mercury, which is reasonably consistent. You could also have repeated the pulse wave and continuous wave Doppler over the pulmonary valve. Sometimes it's hard to get that initial RV outflow in the parasternal long axis, so you may need to use the parasternal short axis. Maybe better to optimize the continuous wave and pulse wave. So now we've moved to the parasternal short axis at the level of the mitral valve. And what you can see here is an enlarged RV, quite enlarged in this image, and a smaller, so it does look small, LV. And it's kind of coming in and out of view, which is why you're kind of losing that donut shape at the bottom right. just optimized a little bit more. And again, we're still at the mitral valve level. The LV function looks reasonably normal. So all of the LV appears to be thickening and moving into the center by at least a third. The RV does look dilated, wrapping around the LV at the top. And then we move to the the apical four-chamber view. What stands out here is the atrial dilatation, so particularly left atrial dilatation, but also probably some right atrial dilatation as well. LV function looks reasonably normal. It's difficult to comment on the RV given that we can't really see the free wall very well. But you do get the impression that the annulus, the RV annulus, tricuspid annulus is moving vigorously. An RVS prime was measured, which is within the normal range, indicating normal RV function by that parameter. And now I've moved to the RV focused view, which makes it easier to see the tricuspid valve. We're still really not imaging the RV free wall particularly well. Colour over the tricuspid valve, and you can see a big jet of TR heading back into the right atrium in systole. And the sonographer, whoever's doing it, has just tried to optimise that a little bit more, but there is a lot of TR there actually on colour flow Doppler. And CW through that jet shows a max pressure gradient of 57 millimeters of mercury, which is consistent with previous measurements. And 59. So this is very common, is repeating the measurement a number of times to make sure that you're being consistent and that you're also optimized. You can see here that there isn't a full signal. We're missing part of the signal in early systole. And so the sonographers just tried, change their position slightly, trying to optimize the 2D image and making sure they're getting the jet within the image, and then optimizing the angle of the Doppler as well, to maximize that velocity and therefore the pressure gradient, and also to ensure consistency. And then we've moved to the IVC, which is 21 millimeters, which is just normal. And I think there's less than 50% collapsibility there. So that would equate to an RAP, or right atrial pressure, of 8. And we saw that the TR max pressure gradient was around 50. So that would equate to an RVSP of around 58, which again is significantly elevated. Okay, here are just some still images again to demonstrate how to measure the TRV max. So you can see here that there's not a full signal, and sometimes that happens if there's an inadequate TR signal, and you can either say there's an inadequate TR signal to estimate RVSP, but you can, and that's probably what this person would report who was doing this scan, but you can also show or kind of extrapolate to where you think the maximum pressure gradient would be. So it's not perfect, but it's fine to include pictures and measurements like this so that other people looking at the scan can use that information in their interpretation. And likewise here, there's a bit of extrapolation there about where the peak velocity is. And it may be because, as I said, the patient doesn't have enough TR to adequately estimate RVSP, or that unfortunately your 2D images aren't adequate. Alrighty. Next example. This is kind of just to illustrate that sometimes 2D images are average, and it's hard to make a call about anything, and this is where you may start when you have a parasternal long axis view, which is what it is, but it's really hard to make any comment based on this 2D image. And these are just some more examples. Showing you that even with poor 2D images, you can sometimes take measurements, although they're never as good as them when you have good 2D images. Okay, so this is probably a bit more familiar. Now we're in the parasternal short axis view, the level of the mitral valve. And what you can see is a very small LV, which appears to be contracting okay, but this is kind of the first view we've got of it, but the impression of a very large RV wrapping around it. And then parasternal short axis view at the base of the heart, at the aortic valve level. Again, pretty tricky to interpret, but the aortic valve's in the middle there. So the RV's at the top of the screen, LV's inferior to the LA, is inferior to the aortic valve. And you can see a little flicker of the tricuspid valve coming in and out on the left of the screen, and the RV outflow tracks on the right of the screen. An attempt at optimization. And then usually you would put colour over that anyway, before the continuous wave Doppler, but this is just continuous wave Doppler where the tricuspid valve is, and there is a little bit of TR there, but a pretty inadequate signal to make any interpretation. And so you may say in this case there's inadequate TR to estimate RVSP. And again, this is now at the mid-pap level. And you get the impression of some septal flattening there, and also an enlarged RV. And again. And moving down towards the apex now. And you can see that the RV still at this point down near the LV apex looks bigger than the LV, and that's abnormal. That's indicating really significant RV dilatation. Now we've moved to an apical 4-chamber view, and in fact at times it's becoming an apical 5-chamber view. And this is normal. This happens. Sometimes people have very difficult windows, and this is the best image that you can get. And an attempt to optimize that a bit and focusing on the RV, which does look enlarged compared to the LV. And again, I think there's a bit of colour over there which I haven't shown you, but there is some TR and measurement of the TR Vmax. And that gives us a pressure gradient of 50, which is elevated. And they've optimized that a little more and got a better spectral Doppler of the TR, but the measurement's reasonably consistent. So we've got a pressure gradient here of 54 millimeters of mercury. Measurement of RVS prime, which is normal. And again, attempt at optimizing the image. And I think we can say the RV is significantly dilated or severely dilated. And you can see that it can take some time and a number of images to optimize it. Sometimes we don't have a lot of time in ICU, but if you can, be patient. It is very frustrating at times. And so they've managed to optimize the image a bit, and now we can see the TR jet there. And with continuous wave Doppler through that jet, we're now getting a pressure gradient of 40. And you can see here, it's a little bit hard to see, but if we just go back and look at the direction of that jet, and then in this image, compare that to the direction of the CW Doppler, which is the direction of the yellow cursor, the yellow dotted line. They're not lining up completely, and that risks underestimating the maximum velocity of that TR jet, which is probably why the number is lower than the ones we saw in previous slides where it was around 50. And so they've optimized the image again and lined up the Doppler more parallel with the TR jet and the direction of flow of the TR jet. And you can see that now the velocity is higher and the max pressure gradient is also higher, so 58. Again, just really trying to optimize the images of the RV. And have moved to the subcostal view of the IVC, which is showing significant dilatation of the IVC at 2.8 centimeters. And really is not collapsible at all. So for this patient, they had an RVSP in the 50s, kind of 50 to 58 range, and a raised right atrial pressure of 13. So they've got, significantly elevated RVSP. All right. Next example, again in the parasternal long axis view. And here we can see a thickened LV. I think that's something that most of us would notice and comment on. And the impression of an enlarged RV given its relative size to the LV. And slightly different view, but same patient. It's still in the parasternal long axis. Doesn't really change our interpretation from before. This is a nice RV inflow view from the parasternal long, so achieved by tilting the beam down towards the hip. You can see the tricuspid valve in the middle there. With colour over that valve, we can see significant TR. And what we're seeing here, we might just go back and see. So it's hard to see, but you may get the impression that the tricuspid valve leaflets aren't actually meeting, aren't coapting, because we have this very wide TR jet. And then when you put the colour flow, you put the continuous wave Doppler over that colour flow, what you're seeing is that rapid equilibration of the pressures. And so this actually may be an underestimation of the RVSP, given that kind of wider open, more free-flowing TR. So when you see that rapid down, or the kind of vertical downstroke of the TR jet, that indicates the rapid equilibration, and then you have kind of this dagger-shaped spectral trace. So you suspect that's underestimating RVSP. And it might be a bit easier to see in this image. So you can see that in the 2D image on the left, it really looks like those tricuspid valve leaflets aren't coapting, and that's resulting in this free-flowing TR. And here we're in RV outflow from the parasternal long axis view, and you can see that little jet of PR, pulmonary regurgitation. And they've measured the RVOT VTI there. And with continuous wave Doppler over the same area, measured the maximum pressure, the maximum velocity, and therefore calculated a maximum pressure gradient, which all looks normal. And this is the spectral waveform of the PR jet. So the spectral Doppler above the baseline shows us the PR, and there you could measure the pulmonary artery diastolic pressure. Now we've moved to the parasternal short axis view at the level of the aortic valve at the base of the heart. And here you get the impression of RA dilatation. And if you look at the septum, it looks like it's bowing towards the LV, which is indicative of high right-sided pressures, high right atrial pressure. And this is colour over the RV outflow pulmonary valve in the parasternal short axis with CW. And again, so this is still in the parasternal short axis at the level of the aortic valve, which it might be a bit small, but again is trying to demonstrate that free-flowing wide open TR, because it looks like the leaflets aren't coapting completely. And then CW through that TR. So with rapid equilibration of the pressures, the velocity is decreased and our RVSP is underestimated. Again, just a 2D image trying to really interrogate the tricuspid valve leaflets, but they're kind of coming in and out of the window. It's a little bit hard to see. And now we've moved down to the mitral valve level in the parasternal short axis view, and you can see septal flattening, I think, throughout the cardiac cycle and an enlarged RV. Move down further to the pap muscle. There is a D-shaped septum. It's a bit less convincing that it's throughout the cardiac cycle in that in this loop, so we'd have to slow that down and have a look. And this is a nice apical 4-chamber view, heading to, probably an RV focused view. You can see an enlarged RV, significantly enlarged RV. And I think here it's probably the clearest image we've had that the TR, the tricuspid valve leaflets are not coapting. And then with colour over that view, again, you can see that wide-necked, that's what we call wide open TR. And with that rapid equilibration of pressures, the peak velocity is low and RVSP is going to be significantly underestimated. And that's just the same again, sorry. And again. Okay, moving on to the subcostal in this patient. So this is a subcostal view of the IVC. And the IVC significantly dilated at 3.6 centimetres. And unsurprisingly, I think there is less than 50% collapsibility. which would indicate a high right atrial pressure, which fits with all the images we've seen here. Alrighty. So again, in the parasternal long axis view, a thickened LV, which appears to be contracting normally. Sorry. RV inflow with the tricuspid valve in the middle there, and colour over the tricuspid valve demonstrating TR. And then continuous wave Doppler through that TR jet, and unfortunately we've blacked out the views because of anonymity, but that's giving a peak velocity of 4, which is a little bit high. RV outflow, a little bit hard to see, but if you put colour on it, it's sometimes easier to see. And you can see the PR jet there. And then pulse wave Doppler through the RVOT. Repeated a couple of times. And then CW, and there was that little bit of jet of PR there, which hasn't been captured very nicely, but that happens. Now we're in the parasternal short axis view at the level of the aortic valve. You can see the tricuspid valve to the left of screen there, and the pulmonary valve flickering in and out on the right. And they've swung the probe around a little bit just to try and focus on that pulmonary valve and RV outflow to optimize the acquisition of the PR jet and repeat those measurements with continuous wave. Oops, sorry. To see if they can optimize the image anymore. And now focusing on the tricuspid valve on the other side. Colour over the tricuspid valve does demonstrate tricuspid regurgitation. So we can CW through that. And that's consistent with the measurement before. And repeat it again, and that all looks pretty consistent. So this is kind of a bit tedious, guys, isn't it? But it's to really illustrate that you do need to take multiple measurements to make sure that you are accurately representing what's going on and accurately capturing what's going on. So parasternal short axis view, and what we can see is a small LV with abnormal septal motion, so that's septal flattening, and the impression already of a very dilated RV. Move down to the mid-pat level, which is showing similar findings. Apical 4-chamber view, which is a more RV focused view. And again, the RV looks severely dilated. Its function is reasonably normal, so the RVS prime is about 10. Visually, I don't think it looks quite that good, but probably need to look at a few more images, which isn't really the focus of this talk. Colour over the tricuspid valve, again demonstrating tricuspid regurgitation. And CW through that tricuspid regurgitation, which again is consistently demonstrating a velocity of 4 meters per second, which is elevated. We can work it out with the equation. The IVC, I haven't got the number there, but it looks probably just more than 2 centimeters, doesn't it? And again, another example of a poorly collapsible IVC, which would indicate a right atrial pressure of at least 8, but probably closer to 15. All right, thanks for sticking with us, guys. That's the end of this talk. See you next time.